things that we see, and I think that some of these are really interesting. I'm okay if this is a little bit more interactive, so feel free to shout out some thoughts, or else this is going to be really boring for all of us. So we will start off with a guy who was seeing spots. This is a 52-year-old man, had 3 strokes previously. He's on aspirin and clopidogrel, and just so that you all know, this isn't a clopidogrel resistance situation. So with residual right upper quadrantenopsia and left lower, so you can imagine he's got one of these things going on right now. And then he comes in, how unlucky, for new left upper visual field deficit. So he's already got this, now he's having this. His last one well was 80 minutes prior to arrival. His CT is here, which you can see he's kind of got this bioccipital type chronic looking strokes, which kind of explain a little bit about what's happened to him before in the past. So the question is, what do you do next? This is the interactive part. Almost. Quasi. So what's next? Anybody? Vessel imaging. That would be a great answer for a non-stroke neurologist. I like it. Vessel imaging, there's something that we always want to do before vessel imaging. No. Yikes. TPA? What's that? What's the NIH? Well, it's probably going to be about a 1 for partial visual field deficit. Let's say 2 years ago. I don't remember. A while ago. They weren't within the last 3 months. Let's put it that way. Somebody has shouted out the answer, I think. But so thinking about thrombolysis, and I think I might have heard someone already say the diagnosis, which is good. But yeah, so thrombolysis. So I mean, this is, you could say his stroke scale is a 1. Why are you going to thrombolyse this guy? He's already got 2 visual field deficits. He's now losing the left upper, and this is a guy in his 50s. So we, at this time, we weren't using TNK. This was several years ago. So this was, I put TNK, but it was actually TPA. Then we did the vessel imaging, so very astute. CTA head and neck, they were normal, so nothing in the posterior circulation, no severe basilar disease, no vert disease. And then his vision began to improve. And again, this was when we were using TPA, but let's just say TNK. And his labs came back as follows. Any concerns here? Platelets, yeah. So back in the day, when we were using TPA, we would say, oh, shoot. Remember, you don't have to have these labs back before you administer TNK. Now with TNK, it's just a bolus, right? So you're like, oh, there you go. Platelets come back at 10. Everybody's like, oh, my goodness, like, what do we do? And then you're just sitting there, like, hoping that nothing happens. But this was, so we turned off the TPA. I think it was like half done whenever we saw this platelet came back. So this was his new stroke on MRI. So it was there. It was real. It was new. And what do you do next? So you have a little bit of information about platelets. We're all neurologists, so we say, go take a better history. So I went back in and I said, hey, have you ever had any problems with your platelets? And he said, no, but my sister has this weird blood problem that she's been told about before, and she's had some strokes in the past. And I said, okay. And so we did a little bit more workup. So his ADAM TS13 was 9%. We'll talk about that in a second. Normal is greater than 70%, which is indicative of hereditary TTP. His platelets nadir'd at 23,000 and had persistently elevated retic count. Hematology started him on prednisone. He received routine fresh frozen plasma for quite a long time, and he had had no recurrent strokes several years later. So take-home points, hereditary TTP and stroke. So this episodic microangiopathic coagulopathy with thrombocytopenia and hemolytic anemia. Stroke and TIA can be a rare complication. Unfortunately for this guy, it was his major complication, and it happened a lot. I don't know why, only in the posterior circulation it was a little bit unusual, and the rest of his MRI actually looked pretty good on FLAIR. And this is basically due to the inability of this ADAMTS13 to cleave von Willebrand factor, leading to systemic platelet aggregation and thrombosis. This classic pentad, if anybody's ever seen it, please let me know. I've never seen this. I don't think I ever will, but just so you know what it is. All right. We have a lot of cases, so I'll keep going. Quick question. According to the AHA-ASA guidelines, which of the following would be a contraindication to IV thrombolysis in acute stroke? Platelet count of 120,000, INR of 1.7, PT of 17, self-limited GI bleed 30 days prior, large ischemic MCA stroke 5 months prior to the onset of the new symptoms. Yeah, and I'm not tripping you all up too badly here. So remember that the INR has to be greater than 1.7, but answer B is still the correct answer. And I think I brought this up because I have seen a couple cases where the INR and the PT did not correlate well. So remember that it's just a calculation off one of another, but the INR is calculated off of controls, healthy controls. And those controls are different in different labs, and they change over time. So an INR greater than 1.7 is a contraindication, but so is the PT being greater than 15 seconds. So just a kind reminder to make sure that you look through both of those and make sure that they're correlating well. If you see an elevated PT, even though the INR is kind of right at that borderline, I would hold off on TNK. So platelets less than 100,000, stroke trauma within 3 months, GI bleed 21 days, or active malignancy are the contraindications for the other ones. All right. Negative TTE. Is the next case. So a 50-year-old with hypertension, alcohol abuse, bipolar, admitted for 3 days of right-sided weakness, intermittent word-finding problems, lives alone, noticed by his family whenever they came to visit him and brought him to the emergency department. This was his MRI over on the right side of your screen, and this is a poor demarcation of what's supposed to show kind of an M2 occlusion. So you have a 50-year-old person with not a lot of vascular risk factors. Any thoughts on workup? DAPT. Probably not DAPT in this. All right. So we're going to do the normal things, especially stroke in the young. Looks cardioembolic to me, looks embolic. His vessels otherwise look pretty good. So did a hypercoag workup on him, which was pretty unremarkable. His vascular risk factor markers were unremarkable, as Telly didn't show any arrhythmias. His echo showed a 50% EF, normal left atrium, mild mitral regurg. So everything's looking good so far. So now what? TEE? Did someone say that? Yeah, I think it's not a bad thought. So we did a TEE, and what is this? This is a classic arrow sign. Made it easy on you. What, I know we're not cardiologists, but any thoughts as to what this might be? PFO, not quite. Vegetation is a good guess. So what else could this be? So vegetation, certainly. Tumor, yeah. Tumor, vegetation. Tumors, what are we specifically talking about when we think about tumors? Myxoma, what else? What's a benign cardiac tumor that we're going to talk about in the next slide, probably? Papillary fibroelastoma. Yeah. So this was actually a stroke due to mitral valve fibroelastoma. Which are benign cardiac tumors. Usually they're located on valves. They're related to this Lambel's excrescence, which you'll see on echoes reported not infrequently. They're usually only seen on a TEE. That thing was huge. At least it looked huge on the TEE, but was completely missed on surface echo. So I don't advocate for TEEs on everybody, but if you have a very embolic appearing stroke in a young person and everything's coming back normal, before you just send them out on a cardiac monitor and then with plans to do some sort of loop recorder, make sure that you do a TEE, make sure that you do some extra labs and look for some alternative causes. So stroke or TIA obviously caused by either a piece of the tumor breaking off or it can accumulate some thrombus on it. You can see here that the risk of papillary fibroelastoma-related stroke or TIAs is not small. And then the question is, what do you do about this? There's no real evidence, but most case reports favor transitioning from anticoagulation in case there is some mobile component or some thrombus there, but surgery. Surgery is what you need to do. So if they're large, if it's a young patient, if it has a mobile component, these patients need to go for surgery. So just push your cardiothoracic surgeons to take these patients because they will be at a high risk of having recurrence. All right. Next case of a little dizzy. We all love dizzy patients. 32-year-old man, no history, presented for second opinion of a basilar stenosis. Had several weeks of dizziness, and at times he would say he was a little bit vertiginous. This was his angio followed by an MRI and a CT scan. This is probably going to be hard to see, but again, if you get lost, follow the arrow sign. What you can see here is a very, very, very focal stenotic proximal basilar. Obviously, seeing this in anybody is extremely scary, let alone a 30-some-year-old with no risk factors. Here on the MRI, what I was seeing is on his flare, there were already some kind of changes kind of right in that pontine area. So probably at some point in time, I was seeing him a couple months after he had been worked up, but he had quite the kind of chronic flare changes throughout that region. The rest of the brain looked absolutely pristine. And then this is the one that really doesn't show up well, but I wanted to make sure that you all understood. This is actually, if you look on the outer portion, there's actually some hyperdensity on this CT indicating likely calcification around that area. So he had this repeat angio whenever I saw him, which was 5 months after his initial, and he basically obliterated his basilar, and it's gone. Fortunately, he didn't have any more strokes. He still complained whenever he was overexerting himself that he would get a little bit vertiginous. But we did this in thoughts of, should we do a preventative stent? Should we watch this? Should we see if he can collateralize on his own? And fortunately, he made the decision for us. He was on dual antiplatelet therapy this whole time. He made the decision for us and basically occluded this on his own, but developed enough collaterals between probably his SCA and his ICA there, and he had an ICA-PICA complex on the left side that you can see here that are kind of coming together, which is very interesting, a lot of good anatomy here. But he did really, really well. The question is, what caused this? So we did our normal workup. We actually went to some extremes for him. We did a 7 Tesla MRI. So fortunately, we have the ability to do 7 Tesla MRIs at the clinic, which showed some basilar wall thickening and actually enhancement around that area. So it shows the vessel wall really, really nicely. His ANA, his ENA was unremarkable. His CSF, we did, because of this 7T MRI, we said, could this be a vasculitic process? We're seeing some enhancement. Some people will argue if you see concentric enhancement, that's vasculitis. If you see eccentric, it's going to be more athero. I argue that we don't know yet. I have seen vasculitis that has been very, very eccentric, and I have seen athero that's been very concentric, so I would not hang my hat on either one of those. But it shows us that this is active inflammation. I think that that's helpful. So that led to CSF, which was relatively benign. No signs of vasculopathy anywhere else or extracranially. His only thing that came up was that he had a significantly elevated lipo(a) at 112. So we talked to him a little bit more. His family has a history of early coronary disease. We sent him over to our cardiology team. They were also concerned about his lipo(a). The problem is with lipo(a), what's the treatment? Right, we don't know. Statin, everybody should be on a statin, and then there is some, I think that there is some role for a PCSK9 inhibitor in situations like this, but the PCSK9 inhibitors have been shown to lower the lipo(a) by no more than about 30%, and that's best case scenario. So we know that the higher the level, the more disease is correlated with it, so you want to try to lower it, but are you going to get him with just a PCSK9 inhibitor to a normal level? Probably not. So there are some clinical trials that are going on that are looking at different treatments, and I hope that we have something for lipo(a) because it affects us and it affects our cardiac colleagues. But I had a lot of questions, and I don't have answers to all of these, but this was a challenging situation in that he was on antiplatelet therapy. He was actually a poor responder to clopidogrel, so this is someone that I saw this progression. I checked his assay. I switched him over to ticagrelor. When do you consider angioplasty and stenting in a patient like this? We did a TCD, so we tried to monitor this non-invasively, but obviously whenever you have that degree of stenosis, your TCD velocities are going to be through the roof. So it's really, really hard to follow any sort of subtle changes. He was relatively stable clinically. We talked about the chronic management, and then how do you counsel a patient like this, right? What is my risk of this causing problems moving forward? What's my future risk? What's the role for vessel wall imaging in patients like this? So this is just a good case to think through a lot of different questions, and when you see something that doesn't make sense, go the extra mile to try to figure this out, whether it be labs or whether it be imaging. I do think that some patients deserve kind of the whole works.
So,
Yes?
as a neuro-oncologist, I probably would have pushed to stent him. Why not?
Yeah, if you don't know what the underlying etiology of this is and you put a stent in, the chance that that stent is just going to close off is relatively high. So in our patients that have vasculitic causes of stenosis and we're trying to get to the underlying etiology, it's really hard to throw a stent in there to a very, very stenotic vessel that's progressing, because then you could say, this guy's 30, what are the chances the stent shuts down throughout his life? And then you recanalized him, he could shut down again with that stent, and now he has a foreign object in there and he's shutting down. Also, whenever we lay a stent in the basilar, what we're also doing, if I go back a couple slides, is look at this nice, big, juicy ICA that comes right off here. So if you lay a stent right here in his basilar, the chances are very high that you could occlude one of the vessels that's trying to help him collateralize. So it's a tricky, if someone was extremely symptomatic and having recurrence and having maybe some small recurrent strokes, I probably would have pushed for it. But in this situation, I think whenever you put a stent in there, you're going to occlude a lot of the perforators. So not only this ICA that comes into play, but also the pons is mostly supplied by all these microscopic pontine perforators, and you just have the ability to potentially occlude all of those, and his brain looked really good otherwise. That's a good question. So that's why I decided not to, but it was something that we were definitely thinking if he would have gotten worse at any time. All right. I had to, just because Glenn's here and he said all those nice things about me, I had to throw him a bone and say something about oncology. So 58-year-old woman who came to see me, had a prior history of lung cancer. I actually emailed you about this patient. You probably don't remember, though. With Mets to the brain and prior whole brain radiation therapy. This was about 10 years prior. Was sent to our clinic for cognitive complaints and an abnormal MRI. So her exam was stone cold normal. I said, something's not quite right, though. We did a MOCA in the office. It was 21 out of 30. And this is a woman in her 50s, high functioning, very, very good job, and never had any stroke symptoms. And this is her MRI scan. Yeah, so the first thing that everybody always says is amyloid, right? You see microhemorrhages, they're scattered, they're lobar, they're also deep, but most of these are lobar, they're very small. This kind of right frontal one is a little bit larger, so this has to be amyloid. Now, she doesn't have this prodrome leading up to this, but she's having kind of some cognitive changes. We'll get into this a little bit more. The problem became, initially you have to say this could very well be amyloid. She had no progression. This was like 3 years. I usually scan these people. Amyloid is a progressive disease. She had no clinical progression. She had no progression on her MRIs at any point in time over the next 2 to 3 years. She was placed on donepezil, and she had an improvement over time in her MOCA to the high 20s, I think within about 3 years. So side case that goes along with this. So 62-year-old guy who has a past history of COPD, hypertension, had an astrocytoma, which was diagnosed in 2019, had some seizures, resected later in 2019, and then chemoradiation until December. He was on temozolomide but had to be stopped due to thrombocytopenia and recurrent strokes. And then he had recurrent small vessel strokes over and over, clinically and subclinically, and all of his surveillance scans that he was getting, there were new strokes. And all of his vascular risk factors were well controlled. So what this gets to, and this is his scan, his CTA showed bilateral ACA stenoses, pretty significant stenoses, along with scattered circular Willis, athero, and stenosis throughout. I mean, very, very, very ratty intracranial vessels. So what this is hinting at is, what are some effects of cranial radiation from a cerebrovascular complication standpoint? And Glenn, feel free to correct any of these because this is my take as a cerebrovascular specialist. Risk factors: being young at the time of therapy, focal, diffuse, or moya-moya patterns, so that circle of Willis that we were seeing that was really affected in the proximal vessels with that last patient. The highest risk is when the circle of Willis is in the field of radiation. The cerebrovascular mortality is elevated quite significantly in brain tumor survivors. You have this severe progressive carotid vasculopathy. Be cautious with stenting. Okay, if someone has a history of radiation, you see carotid stenosis, these patients typically do not do well with stents. Screening vessel studies 5 years after those that had circle of Willis radiation, and then every 5 years thereafter, usually with an MRI and an MRA. Aspirin for primary prevention if you see some vasculopathy is recommended. And then increased microhemorrhage and calf malformation reported in anywhere from about 40 to 90% 5 to 10 years after radiation. Careful with CA misdiagnosis here. So that first patient, she remains stable to this day, and she's doing really well, and her MRI has not changed a single ounce from the first time that I ever saw that MRI. I'm gonna take a quick detour and also say, if you see an amyloid-looking MRI and someone who has had a history of valve problems or valve surgery, we see microhemorrhages that mimic CAA all the time in patients that have had a history of valvular disease or history of valve surgery. If you think about it, the risk of them embolizing is really high. They go through valve surgery, they're on a lot of heparin. After valve surgery, I see these patients years and years later, they have an MRI for something else, and they have a brain that looks just like amyloid, but no clinical features of amyloid. And then you go back and say, have you ever had valve surgery? Oh yeah, I had rheumatic heart disease. I've had 2 valve surgeries, et cetera, et cetera. So progression with amyloid is very, very common, and that's what you should expect. And then SMART syndrome, stroke-like migraine attacks after radiation therapy. Can include seizures, can be seen within 2 years of radiation, but many decades later. The vasculature is normal in these patients, so if an MRI is normal, an EEG is normal, consider something like this. If you're getting people with focal symptoms, think about SMART syndrome. How'd I do? All right, I got a thumbs up. All right, we're getting there. Patient with prior lobar hemorrhage and probable cerebral amyloid presents with brief episodes, several minutes of progressive left facial numbness and paresthesias, reported visual loss, and at time has some flashes in their vision. These have occurred at least 3 times in the last 2 weeks. What's the most likely diagnosis? TIAs, cerebral amyloid-related migraines, seizures, transient focal neurological episodes. All of these are on the differential. So yes, just remember that if a patient has amyloid, you have to think about these TFNEs. So I see these diagnosed all the time. I get patients in my clinic all the time that come in for a TIA evaluation, TIA or seizure. They have amyloid, or their MRI is very consistent with amyloid, and everybody treats these very, very differently. So these TFNEs, or amyloid spells as they're referred to, are typically these recurrent, brief, and stereotyped episodes. The important thing here is that they can be negative or positive, or both. So remember, if they're all TIAs, they should just be negative symptoms. So if you see a combination of these, and also this cortical spreading depression, so they sometimes progress over time instead of a TIA, which would just be there kind of right up at the front. And then they're oftentimes related to a new microhemorrhage, cortical superficial siderosis, or subarachnoid hemorrhage. So it's important to differentiate between TIA seizures and migraines with these, because obviously the treatment is much different for the other ones. All right, I think we're doing well. This is my last case. Not feeling like my normal self. So 23-year-old woman with a past history of unilateral renal hypoplasia, just found incidentally, she never really had any problems, said that she just wasn't feeling like her normal self. She was having some visual changes, but kind of these vague, it wasn't loss of vision, it wasn't that she was having double vision, just her vision wasn't quite right. Sometimes she would see spots, sometimes maybe she lost a little bit here and there. This was her MRI scan. Sorry I didn't put an arrow sign. I figured you all are seasoned by now. One teeny tiny little punctate DWI change kind of here in the right parietal area. So initial thoughts that we had, many people had, this was a transferred patient in, but a lot of people thought this is likely demyelinating disease. This is a young woman. Could this be a cryptogenic stroke? Carrie's screaming from the audience here. Had MRI, spine, and orbits, no lesions anywhere else. Cardiac telemetry was normal. Echo was normal. TEE was normal. CT chest, abdomen, pelvis. They said, is this malignancy in a young person? That was all normal. Her anticardiolipin IgM was a little bit elevated into the mid-40s, but again, that can be an acute phase reaction. So whenever we're thinking about the antiphospholipids, we have lupus anticoagulant, we have anticardiolipins, and we have beta-2 glycoprotein. So it's important to check for those three things. This anticardiolipin IgM is oftentimes elevated in an acute phase, so it can definitely trend back to normal. And if people are going to have a lupus anticoagulant or antiphospholipid syndrome, they're usually triple positive. So anyway, this raised some red flags, but not a lot. And then she was sent home with outpatient hematology follow-up, and guess what? Dual antiplatelet therapy. Why? I have no idea. Not an indication here, okay? But you all know that now. Returned a few days later with worsening visual complaints, and again said, I'm just not feeling like my normal self. MRI. Obviously looks different than what it did just before. Does somebody want to say what they see? What's striking about this MRI? Yeah, the location. Susac. Someone already screamed out Susac. So the location of this affecting the corpus callosum, so the genu and the splenium are both pretty affected here, and this is all brand new from a week ago, so something's active. The vascular supply to the corpus callosum is very robust. So we normally don't see strokes in the corpus callosum very often, not due to embolic phenomena, not due to athero, unless it's really, really bad, and obviously in a young person it's not. So yes, so we said, I don't think that this is demyelinating disease anymore. This could be Susac or some form of vasculitis. The ANA also came back at 1 to 1280. Just to let you know, 1280 is the highest that we can test for. So it might have even been higher than that with a speckled pattern. So what do you do after this? Treatment, right? Yeah, so steroids. Any more workup that anybody wants to do? Are you all convinced before you start steroids? Are you convinced about your diagnosis? You had this anticardiolipin. Could it be lupus? Ophthalmology evaluation. Love it. We tapped also. LP did show some pleocytosis, so we're moving in that direction. And what do we see here? So this is a fluorescein angiogram. And what I'll point out is that this is probably one of the best pictures of what's the classic finding in Susac on a fluorescein angiogram. Branch retinal artery occlusions. Wow, lights are dim. This is great. Thank you. So all of these little areas here are basically where you see seepage and breakdown of the barrier here within the vessels. And then this one is probably the best view of this should continue. And you can almost see the shadow of where the artery is supposed to be. So here there's active inflammation, active inflammation, active inflammation, active inflammation with a very clear branch retinal artery occlusion. Both of her eyes had very, very, very clear occlusive disease. Just be cautious. If you look down at the bottom, these are eyelashes. So the eyelashes are always part of the screen, but there is a very clear branch retinal artery occlusion here. So audiogram also revealed low frequency bilateral hearing loss. So remember, low to medium frequency hearing loss is typically what we see in Susac. Started on steroids and also IVIG. There is some data to support that maybe doing both of these up front is helpful. Also rituximab with clinical stability before she left the hospital. So take-home points for Susac, it's a rare endotheliopathy, usually affecting small blood vessels of the brain and the eye. This clinical triad is only seen in about 25% of patients. So if one of them is missing, that's actually more common. So if you have any clinical suspicion, it's important that you investigate this. Characteristic snowball and icicle lesions of the corpus callosum. It's important probably to get some CSF analysis here, make sure that you see some pleocytosis, but again, it doesn't have to be there if your clinical suspicion is high. And then the treatment can vary. Susac is extremely, extremely rare, but usually involves immunosuppression of some sort. All right, look at that, 20 seconds.